Hello, good evening, and welcome at another episode of EAO's Just Ask, your monthly live appointment with a leading expert in implant dentistry. My name is Gerrit Heijkoop and I'm the host of this EAO channel, and tonight we are going to try to answer all your questions about innovative pre-treatment options in prosthodontics. And more specifically, we're going to focus on the Munich splint concept. And to do so, I'm joined tonight live from Munich by Daniel Edelhoff. Daniel, good evening.
Good evening, Gerrit. Great pleasure.
Nice to see you. Yes, you are one of the leading scientists behind the development of the Munich splint concept. And that is probably because you combine a unique set of skills and expertise, being a certified dental technician on the one hand, also having a lot of experience in science of materials, in material science, and also at the moment being the Dean of the Studies in Dental Medicine and the Director and Chair of the Department of Prosthetic Dentistry at the University Hospital in Munich. So you're the right man for the job tonight.
Thank you.
In the meantime, like some of our regular viewers are already doing, I always find it fascinating that we are live tonight on the EAO channel on YouTube. And I invite all of you to make use of the fact that we're live and submit any questions that you might have for Daniel during the conversation. I will relay them on your behalf, and to kind of warm you all up and get a feeling of the international spread that we have. I just posted a question to you in the live chat. Let us know, where are you joining us from? And I already see that Boszczan Poland is joining us from Slovenia. Victor Palari is also joining us again from Moldova. So Victor, welcome as well. And if you're now watching this, please let me see that your keyboard is working and let us know in the chat who you are and where you're joining us from, because then I know that also your questions will come into us live. Daniel, let us kick off. We're going to talk about pre-treatment options in prosthodontics. The Munich splint concept. But before we zoom into that, let's start with a question of identifying who is this for? What type of cases are most likely benefiting from this concept?
Okay, Gerrit, we started actually with small cases, more from the aesthetic standpoint, on implants like 4-unit bridges. And we saw that sometimes we made mistakes in manufacturing the ceramic, and we had to adjust at the end point of the whole treatment. Now we do it in a different way. Thanks to CADCam, we can manufacture our idea for the patient, and he can, with the polymer, I can adjust, I can add something, I can put something away and change the phonetics and the function and the aesthetics, of course. But then we developed further this idea for complex rehabilitations. That means, especially if you start to change the vertical dimension of occlusion, that makes a lot of sense because we saw the function. The function does not be very precisely simulated in a mechanical articulator. And so we can now transfer the wax up in a removable splint, a bimaxillary splint in some cases, upper and lower. And then you can check phonetics, aesthetics, and functional concepts, the occlusional concept that we designed in the wax up for a long time period, up to 1 year or longer, or 3 months, what you want.
Exactly. So in that form, it's kind of a blend between a provisional prosthetic and actually a diagnostic tool to make the final design. In the meantime, I see from the corner of my eye that our audience is warming up. We see May El from Tehran in Iran. Per Ottostad is back with us from Norway. Thomas Gasser joining us from Zurich. Martini from Austria. And Wim Slot also joining us from Groningen in the Netherlands. Good evening, Wim. Yes. So this is all functioning well. So you say the more complex cases, and specifically if you want to make vertical adjustments. But before we zoom deeper into the concept and how it works and what it means, let's zoom out a little bit and understand which are some of the key developments and technologies that led you to this idea. What were some of the key historical steps that led us to this concept?
This is a very good question. We started with an analog idea, let's say 20 years ago already. We tried to bring it into PMMA, analog manufactured powder liquid systems. But then they fractured very fast. So a milestone in the development to this new idea with the Munich splint was actually the introduction of CADCam technology, digital technology in dentistry. So by these machines, we could mill new materials which were not available in an analog way, like polycarbonate. And this is a very tough material which does not fracture, and you can only access by CADCam measures. And I would say the main milestone in the whole way is the introduction of digital dentistry into prosthodontics and, of course, in dental technician work as well. And this made materials available which are completely new, more tough, more you can work it out very nicely, very fine, 0.3 millimeter thickness only. And this was a breakthrough, an eye opener for these new materials. And you can use it by this, like a non-invasive restoration, like a splint you put on, and you can remove it like a reset option that you have all the time, like a snap-on.
Exactly. Now help me understand two things, because the introduction of CAD-CAM imaging, I understand. It's digital diagnostics, it's modeling, yes, it's design, but you say it also led us to the use of new materials. Where's that link between the digital scanning and imaging and the new materials? Can you explain?
Okay, so like you said, Gerrit, we have to differentiate the diagnostic analysis, where we have a breakthrough as well by 3D scanners, you bring the patient 24 hours and 7 days into the lab. The lab technician can work with the patient all the time, virtual try-ins. But the other thing is we access by these techniques completely new materials. So we have, I show you this blank, for instance. This is a material that you cannot work with. It's a killer application for analog techniques because you cannot access this material without CAD-CAM technology. So you can transfer your idea into a virtual wax up and then transfer it into a prototype, which can be a polycarbonate material like a splint or others. Yeah, this is new.
Clear. And I think by now we would love to see what it looks like. You've brought some images with us to actually show. You say it's, yes, it's a splint, it's a provisional. Please talk us through and show us some imagery. In the meantime, I will welcome some of our viewers who are saying hello. Dr. Rada Al-Rawi from Iraq in Mosul in Iraq, I should say. Welcome as well. And we have Miguel Brites. Good evening. Good to see you, Miguel, as well. So we can now see your screen. We see a case in front of us.
Yes.
Talk us through.
And this is a nice guy. He is an orthopedic doctor, not orthodontic doctor, but orthopedic doctor. And he's 25 years before. He was young, nice looking, according to his wife. It's how they came both. And she complained about the differences in the mouth area, and you see it now. When he opens the mouth and starts smiling, he has some gaps. It smells for the use of implants already, but this is not the only thing. He needs a wax up. He has a loss of vertical dimension of occlusion, and you see it on the left picture now very clearly, lateral, but also in the central. So we did first wax up. This is nothing new. All of you, all the audience, all the participants know it. We did a wax up. And what we changed was the height of the lower face. You see it on the left lateral view. In both cases, he bites together, but this one has an increase of vertical dimension of 4 millimeters. He looks younger now, and he has another dimension of the teeth. Now, his wife, she asked us, when can he get it? I like it. Yeah, he looks like 25 years younger, which is not true, of course. But however, I said
what she felt, yeah.
She felt like this, like the marriage 25 years before. Yeah. So she asked me, when can he get it? And I said, if you want, next week. And she said, what? It's impossible. All the other dentists, you are the fifth one. They said it looks like it takes about 1 year time with implants and all the perio and buildups. So I said, you can get it next week. And what we did a scan of the wax up. We did a scan of the preoperative models. So that's a real situation, what you see here. And then we scanned also the articulator. So that means I have to transfer the positioning of the models to each other. And then you can put it in centric relation into articulator, put the articulator in a lab scanner, and you scan it. And then finally, you have the opportunity to transfer it into the software, which is in this case, very smart software. It can simulate the movements of the articulator. So what is new now? The new is that you can superimpose these both scans. That means this is a wax up on the right-hand side, and on the left, it's a preoperative model. You have to extend a little bit into the undercuts. The goal is that the splint will have a snap-on effect. So you have to extend this material into the undercuts. Then you can design, you can send all the digital data onto the machine, which is a milling machine in this case. You can print perhaps in the future as well. In the moment, we like to mill out of these blanks. And then finally, you get two splints, in this case, two splints, bimaxillary splint concept, one for the upper, one for the lower, according to the wax up. So I think I stop here only to show you that he has now the new splints. It was not 1 week later, 10 days later, but you see, that's
there was a weekend in between, yeah.
In between, all right. And she was happy. He was not happy. He said, horrible, too large. I don't like them. And that shows also that the patient has to be adapt. It's a prototype we can change. It's an explorative tool, but he has a splint. He can remove it if he says, okay, doctor, that was it. I don't like it. You can take it out. You can reset to 0 again.
Okay. Let me, if you take down your screen for now, because then we talk again. So you said he, in 10 days, walks away with a provisional prosthodontic solution of his new teeth, so to say. But this is not the end of the protocol. What follows then?
Okay, so you have not treated the patient. That's a whole treatment plan. You need perio, you need build-ups, you need to insert the implants and all this. But this you can now proceed underneath of the splint. So you take it out, you place your implants, you do your perio before, of course, you make new build-ups, revisions of the endos if it's necessary, and then you can work all the time underneath of these splints. So in other words, in some cases, 3 months would be enough. In other cases, a splint wearing time might be 1 year, no problem.
So you say the link for the implantologist watching tonight is that this is actually kind of like a building cover. So you have function, you have aesthetics while you work. And does this then allow for any, for example, if I need to do surgery or bone remodeling, can this also be covered by these splints, or are there certain areas where you can't go?
You can shorten the splints to create more free room for your surgery, avoid any pressures on your wound areas. So you can use it all the time. And the advantage is actually that if it's fracture, sometimes they are very thin and they fracture, you can reproduce it because you have the file. And I would say in 2 hours, you have a new one if it's necessary. And the other aspect is, if you wait at least, that I would always recommend 3 months, the patient starts to engrave, I would say, implement his wear facets. And we found wear facets on the splint that we cannot reproduce in the articulator. That means it shows also the limitation of the articulator, the mechanical limitations. And the wear facets are not something bad, it's something good, because we like to transfer these wear facets, these freedoms that the patient takes himself as a sense of a long-term registration. We transferred into the final restoration. This is something to avoid overload of the ceramics, for instance. Yeah. So we are test driving with a polymer, like a polycarbonate, but the final restoration should be a ceramic, a metal, what you want. Yeah. What you select for the patient.
So what I understand now is that you say there are already two, maybe there are more, but there's two applications how you use the splint. One to kind of immediately show the aesthetic new outcome and have a discussion with the patient and or his or her significant other. Let's call it. In this case, it was a wife, but significant other. That's one. So it aids the conversation. The second application, you say, you can actually have a provisional restoration and work underneath it, whether it's surgery or whatever you need to do. And now, as a third benefit, you say you actually have this hard or soft material, which now kind of improves your occlusional design. Is that how I should understand it?
Yeah, you can very well described, Gerrit. It's like you give a certain idea of the occlusal concept, and the patient will refine it. And I think in our times where we use a lot of monolithic materials, like zirconia monolithic or ceramic in general, monolithic, we need a very fine adjusted occlusion. Otherwise, you have overloads on the implant. And if the crown, the bridge, or the superstructure is too strong, it will destroy the implant in some cases. So with these overloads, we can avoid by these measures, by this concept.
Perfect. I see some first questions coming in regarding the materials. Victor, Thomas, I'm coming to your questions quickly. But first, to fully understand, in these different cases of application, so to speak, are there certain cases where it's more worth it to use it? Is there a use case that it's best applicable, or do we need all three of them? How do we rank them?
So the prerequisite for the Munich splint, for a complete splint like this one, is actually that you with a bimaxillary concept, one in the upper, one in the lower, according to the wax up, you need a certain space. Mm-hmm. And the space should be, if you look to the incisal pin area of the articulator, it should be an VDI, vertical dimension increase of at least 4 or 5 millimeters, better 5 millimeter. You find these cases. This is one example. We have a lot of such cases, and this helps a lot to have the necessary space for the thickness of the material. Otherwise, they start fracturing. If they are too thin, they start fracturing. Even the material is very tough.
So you say 4 or 5 millimeters in a bimaxillary application. What if you do a single side? Is it then half of that thickness? Or
I would say very good. 2.5 to 3 millimeters should be enough normally.
And that then already shows that it is in quite severe cases, right? Because that is not an everyday case where you come across these kind of modifications.
No, it's not an everyday case, of course, but it brings a lot of security and predictability in this whole case. And it's a very nice tool to communicate with the patient, because according to his wishes. And at the end, in the final material, which is very expensive and very hard from the material properties, you cannot adjust so much anymore. Yeah, so that helps you in some cases without any adjustments to transfer this wear facets and all the occlusal scheme into the final restoration.
Oh, very exciting. Let's take some first questions from our audience. Victor Pallery, a former expert on these Just Ask sessions as well, was the first one who kicked off. And he says, which are the best materials to use during occlusional rehabilitation on lateral implants, combining reconstruction of a smile involving soft tissue corrections? Ooh, that was a lot of... So best materials for occlusional rehabilitation on lateral implants, he says, combining the reconstruction of the smile and involving soft tissue corrections.
A very nice material if you like to test drive something without a splint, fixed. You need for corrections of the soft tissues something fixed. Otherwise, if you take it out and in, it's not exactly what you want. Yeah. So I would recommend PMMA. It should be a polymer that you can correct, and you can polish it in a nice way, and it's had not a very high plaque adherence. So it should be a CADCam manufactured PMMA material, and almost all the manufacturers are offering it. If you go.
Exactly. And you would say in this case, when you deal with the soft tissue modifications, it's a permanent provisional. In a sense, it's not a snap-on, snap-off kind of solution.
No, it should be a permanent. Then you can, then you have a continuing pressure that you can modify still, but you can keep it on in position. This is important for these cases.
Yeah, and I think Thomas Gesser's question is kind of in the same ballpark, but the other side of the same coin. So he writes, what materials do you recommend for full arch snap-on provisionals? So this is snap-on, but a full arch.
A snap-on full arch. This is the polycarbonate I'm talking about. Yeah,
it's the material that you also have there with you.
This one is made of polycarbonate. You have it in your car, so your anterior lights are protected by a clear polycarbonate. So it's a very tough material. So it will be almost undestroyable. And this you can order as well in tooth-colored monolithic, but bichromatic as well. So you have two layers like enamel and dentin. And this is a very tough material. You will not find another polymer which is tougher than this one. This is my recommendation for snap-on.
And so the interesting bit here is that the material is hard enough and strong enough to do all the load, the primary load, the dynamic loads, everything, yet at the same time allows for the slight modifications of the wear.
On the one hand, it's strong enough, tough enough to really stand these extreme loads. But on the other hand, it's also from the wear behavior soft enough to show wear facets in a short time period of, let's say, 2-3 months. That's a minimum wear period that I would recommend. But you can use it for 1 year. You can renew because you have reproducibility options by the file, but normally we use it at least 3 months and the healing period of the implants as well.
Exactly. Well, Thomas says thank you. So that answer was very clear. In the meantime, I see a lot of people joining in. I mean, it's Monday night again. It's 1 week later than normal. Normal, it's the first Monday of the month, but we're here on April 12th. If you know anybody who might find this interesting, either now live or in recording, make sure you share this video with them so they can learn from this as well. Quick shout out to Berus Arefnia from Graz, Turkur Ornikol joining us from Istanbul, Mitchell Pierce, you were here very early today, good to see you again from New Orleans, and a question from Serdan Konatar joining us from Belgrade. It writes, how comfortable is it for the patient to wear this kind of splint, and how does he or she take care of the oral hygiene? Can you comment on that? What are some of the patient-reported outcomes with this concept?
It's a very good question. Normally they like it. Yeah, it's a little bit softer than natural tissues, and I mean enamel or ceramics, of course, but they like it. It's a nice combination of the wear behavior and hardness. They accept it like a normal splint, I would say, like a normal mono maxillary splint that you know already. And how can they clean it? Very easy, by taking that out. We call it a 23-hour splint, so 1 hour for cleaning. So it's removable, snap-on. It's an advantage. It's easier to clean than something other, permanent temporaries, for instance. Yeah. So this is no problem. The problem, but perhaps this question will come, is eating.
Let's take it now. Yeah, exactly. Yeah. How about eating with this personal solution?
This is a problem. Normally, I forbid, I do not permit my patients to eat with the splint, but they refuse, of course. And what you can do is...
You say from your doctor perspective or dentist perspective, from your scientific perspective, you say take it out when you eat, but yet you see in practice, they don't.
It's not because of the health, it's more because of the risk of fracture. So they can move a little bit, and you have it in a wrong position, it fractures. What you can do is that you use the adhesive from the full dentures. It's a small drop that you can place quadrangular on the canines and second molars, only a small drop, and then it's relatively secure in the position, but you cannot, I tell my patient like this morning, please eat boneless.
Yeah, exactly. And then you talk about the food, right? Not about
Yeah,
their.
yeah, as a
No, exactly.
food. Yeah, in the moment, later on with the implants, you can start, and the permanent restoration, you can start eating almost all. Yeah, but in this phase, not.
So careful with eating hard materials and or apply some fixture. How about that second part of the question about oral hygiene? Do you recommend any certain techniques or fluids, or how should patients clean these provisionals?
So sometimes I recommend my patients to use chlorhexidine gel, the 1%, and then you can apply it onto your toothbrush and you can clean some areas. But normally you can really continue with your normal measures of hygiene, no problem at all. And the splint you can also clean with your brush, with the normal brush and water. I would not recommend to use these tablets, which are oxygenizing and cleaning the splints. That has a bad effect on the material. It makes it more brittle. So I like to have an elastic material. To making it more brittle is not my goal. So simply with a brush, clean it up, perhaps with a little toothpaste, that's fine.
Perfect. Well, very, very practical advice here on EAO's Just Ask. However, EAO is also all about science. So let's make a little corner into the scientific background of this. Obviously, the concept was derived in some very well scientifically documented techniques and technology and concepts. But how much research is there into this concept and to the outcomes? Let's start with the timeline. When was the first time you applied this?
So the first time we applied this idea was actually in an analog way. And we used the powder liquid system, PMMA, and it fractured. So we left this idea again. It was so disappointing. So
and
this
approximately
idea,
when was this?
it was, let's say, 2001, approximately.
Exactly. So almost 20 years ago.
Yeah. And then we started with the availability of this material. We started 2010, 2011. I would say the first patient was 2011. So it's 10 years now. It was very difficult to design. So it's a really challenge for the dental technician. But I was excited. I had it in my hands and I did not admire the dental technician. He was a little bit sad. I said, thank you. Can you do another one? He worked for 3 weeks. Yeah. So now the software is much better, almost automated. And now it works relatively easy. It's still difficult, but much easier than at the beginning.
Mm-hmm. Okay, so that was 10 years ago. I found the key publication, or one of the key publications that you wrote about this, was in 2017, I think. Can you share some of the findings and the research you've been doing towards this concept? What are you measuring?
What we are measuring is actually the elution, the strength, of course, but also the elution of some parts of the material of the resin. But we found not a higher level of elution than compared to other polymers. So this is possible to use it as a removable splint. And this is something which is also confirming to the medical device laws,
Regulations,
regulations in Germany, and I think worldwide. So if it's removable, no problem. If you use it as a permanent restoration, what I never do, it might be a problem with some of the materials, but in general, it's no problem. We're using it in hundreds of cases just now.
Yeah, so this is scientific research in the area of the material and the material science.
Yes.
How about the intended outcomes? Have you done any studies? Does it indeed prevent chipping or other failure in the final restoration?
We're just starting with this. I have the imagination, but this is not evidence-based. It's eminence-based, I would call it.
Yeah.
So we have the observation that we have dramatically dropped down of the chipping rate. Yeah. So we give the freedoms of the occlusion, the fine adjustments of the occlusion is made by the patient, and this avoids overloads. And and this combined with our concept of certain selection of the ceramics, it works very reliable, I have to say. And it's another dimension now, because if you insert your superstructures or your crowns or natural teeth or implants, you have not to adjust anymore so much. Sometimes in most of the cases, so minimal that you cannot compare it with old-fashioned versions and that you followed years before. So I'm very glad about that as well.
Exactly. So the first results are very positive. The patient-reported outcomes are very positive.
Yeah.
I see a lot of positivity here. Let me challenge our audience. We see that Kristina Ivancheva from Bulgaria is joining, Stefan Vukacic from Austria, Brenda Mertens joining us from France. Hi, Brenda. Good to see you as well. Let me challenge you a bit to come up with some questions for Daniel Edelhoff, because we are live on this EAO Just Ask, and it is, as the title say, just ask, and I will read your questions on your behalf. In the meantime, as I was leading up to the question, you knew that was coming. All this hooray, all these benefits, they must come at some cost somewhere, right? What are some of the drawbacks of this solution? Why would you not choose such an application?
I would use this in many cases, but there might be one problem would be the price.
Mm-hmm.
So it's
Tell me
not
more about it.
So I can only speak for Germany. It's about, if you have a bimaxillary splint, it's much more than 1,000 euro. Yeah. So we have the cost for the wax up. If it's a full mouth rehabilitation, like this guy, I can show you some other pictures only to show you the wear facets and all that. But this, I would say, predominantly it's the price. And you need also a special equipment from the lab standpoint, of course. Yeah. But you have to know how to modify. It's not so easy. It's a CADCam polymer. So it's not, you cannot simply put other resin on it, on other polymer. It will not really interact very nicely. You have to air abrade and use a special primer. Then it works nicely, but you have to know it's a very specific technique. It's not that you start tomorrow and it will succeed in all the details. You have to know how to work with. So in other words, you need a education to use it.
Exactly. There's a bit of a learning curve.
Yeah, it's a learning
machinery
curve.
In the materials.
Machinery, so it's a price. Again, the costs. That's the other point. But on the other hand, you gain time at the final restoration because you have all tested phonetics, mimics, aesthetics, and function as well. Yeah, so this is not possible with the splints that you have available today with the reposition splint, for instance. Not possible.
So I guess to have an indication of the value and of this investment, both for the patient and for the dentist or the technician, is worth it. We would need to look at how often you modify the splint, right? Because if we modify the splint, it proves that if we would have made the final restoration off the bat, then we would have gone wrong and had a failure. Do you have an indication how often these tweaks occur?
So one important thing is you should not follow the wishes of the patient the first 2 weeks. Because
tell me more about that.
Because all the patients say if they have worn dentitions and they have a decrease of the bite of the height, they will say it's horrible. Yeah, it's
they
too
probably
much.
Get their muscles get tired and all that stuff. Must be weird.
So it would be, you should not change it. It's not about the vertical dimension of occlusion. Mostly they like it because the face is more, you look younger and all the people like it. Yeah. Exactly. You change the profile. It's more convex with the splints, with the height, and you change the lower facial height. That's something which makes you younger. They complain about the size of the teeth all the time. Yeah, in the beginning. After 1 week, they get some compliments. People on where they work, they say, "Oh, you look different, younger," but I do not know why. And then they said, "Start really?" And they come back, and then perhaps they complain about the splint because the splint is not separated enough. It looks like one block, and that you can change by staining. Yeah, by staining, it looks really separate. I'll show you perhaps later another picture.
Why not go ahead, show us, because I know you have a deck of pictures with us. We're curious to see as well.
First of all, you have seen the picture where he inserted it, and now I would. Do you see it?
No, not yet. You have to hit the share screen button.
Okay,
and then you
I
come
share
back.
the screen button. I come back. I will be here.
In the meantime, let me say to our audience, we have some questions coming in. Keep doing that because we will relay all the questions as well. Yes, here is our here's our gentleman again.
Okay, the gentleman was one of the first meetings where we inserted the splint, and now we did some extractions. You can remove pontics of pre-existing bridge work, FDPs. We will look to the opportunities to reline, so you can air abrade the areas where you have to add some resin, like here on the left-hand side, and then we can add again some areas where you place the implants. You see?
One second, Daniel. Help me understand that previous image. You're pointing at the dark areas. What are we seeing there?
In these areas, we either extracted teeth or you remove pontics from existing bridge work. Yeah, so you have a gap to create space to insert your implant. Yeah. So for the meanwhile, we reinforced this area we closed by a flowable composite. And the bonding onto the splint is not so easy. Like I said, you need to air braid. You have to place a special bonding, especially made for the splint. And you can use any of your composite to reline the splint. So it's three things: airborne particle abrasion, P primer, A, airborne particle abrasion, P primer, C composite. Then that's it. And this is a preoperative situation. You see, he's not finished with the treatment. It's on the first day radiograph. You see that we have some silver posts over here, which are in this area of the bone. We see that there are some areas for implants. And in this situation where we have not pre-treated anything, we inserted the splint already. Yeah. So he has a long time period to adapt. He can try it phonetically. He can take logopedic if it's necessary. We had only one patient just now out of 60, perhaps, from my personal side, where we used logopedic with the splint, which is helpful as well if we do major changes. Here we
just a quick pause on that comment, Daniel, because I'm thinking if I need logopedic treatment or training after I have received my new teeth, isn't the model off? Why would the model still be fitting if I need to train my speech again?
I did not understand. So
what happened? I'm thinking, of course, I want a nice smile and I want immediate results. But if that means that my new teeth take me to the logopedic treatment, it kind of feels like the cure is worse than what we're fixing. Can you share a little bit about why that was necessary?
Now I know. I have to underline and emphasize, it's only in very rare cases that you need logopedic problems. It's a S sound and the F sound in the most of the cases. So we had, let's say, perhaps two patients just now. The advantage now is that you can modify the splint because it's still on the polymer modus. You can add something, you can remove something. If it would be the final restoration, you have some problems. Yeah. True. With this combination, if you integrate this, it's in a pre-treatment phase, it's perfect. Yeah. And we have no patient just now who could not speak a clear S, like Mississippi, or greetings to New Orleans and this area. And of course, no patients with the F sound problem. And as you can see, this splint can be used also, the STL data, which are surface data, to create implant guiding templates, and for the insertion of the implant. And now I like to show you how nice the splint can look like. This is still the splint. Would you believe? It looks not like a white wall anymore. It looks separated. And we simply used something to paint it. Yeah, they are special. They are special, like a varnish that you can stain in the areas and looks much more vital. Yeah, with opal.
More natural.
Yeah, more natural. Yeah. And now, if you have this complex rehabilitations, the main question is now, how can I transfer it to the final restoration? And I like to show you this. You have the splint now, the implants are inserted already, and the patient is impatient. Yeah, he says, okay, let's do it in 1 or 2 days, all finished into ceramic. And this is not wise. To do this, I always recommend to make it in steps. The maximum of what I would do as a first step would restore the upper against the lower splint. And you can segment actually into quadrant. What we do in this case, we separate the splint. I prepare the first quadrant. I can take a bite. Yeah, you can do it in 1 day easily. Half a day, this preparation. And in the afternoon session, let's say you prepare the second quadrant and you extend the bite. So the antagonist, the lower, the mandible is actually the splint. This is a antagonist occlusion. You can take an alginate impression of the lower splint and then you insert the upper restoration with the implants, with gold. If you want, you can do it in ceramic. We selected lithium disilicate in this case. And then after 4 weeks, you start with the lower jaw. Exactly the same, separate, segmented transfer of the bite. And you see again, first preparation of the fourth quadrant, then take a bite. And then you remove the splint, prepare the third quadrant, and then you can extend the bite. It's very, very clear and very easy.
And Daniel, help me understand, why is it important to do it in these segments? Is that to prevent any horizontal offset, or why are you doing it
exactly
like this?
Gerrit, it's important because the more you make, the more steps you do in one piece, in one appointment, the more mistakes you are doing. Yeah,
exactly.
it's
more
much
chances for error.
Yeah. It's a higher risk for mistakes or imprecision transfer. Clear. And what I like to show you, we are almost finished and it explains it very well, is actually that we have the splint, we separate the splint, we do a bite registration, and we call this splint actually a long-term registration. That means we can turn complex rehabilitations into more simple quadrant dentistry. The patient is test driving, he likes the situation, and you can select the quadrants that you like to restore. The maximum again would be with a bimexillary concept, the upper against the lower jaw, not more. Not doing both together, it's too risky. And this is something, 1 minute, which is very interesting. In the beginning, I was so, I would say, disappointed because we have wear facets inside the splint and we lose a little height again. But now I consider this at a benefit. Yeah, I do not complain about the wear facets. I integrate it into the final restoration, and this makes a huge change in our risk factors for chipping and overload on implants and on natural teeth as well. So what we like to avoid is actually, especially in the anteriors, constriction, lack of space, because especially the bruxers, they start to move and to create space again, and he did it already in his splint. And these wear facets can be finally transferred into the final restoration, like you see over here, upper and lower jaw.
Okay. Interesting. Well, questions are coming in. Let me start with a really recent one, Daniel, which is related to what you've just shown us. Sverdan Koneta writes, would it be more precise to just send the splint to the lab or scan it in the office? Why are you making a new wax up in this case?
That's a very good question. So this is again a question about being on the CADCam digital way or the analog way. In this case, we used, it's from 2014, 7 years ago, we used analog way. We pressed, we have the gold inlays, which were onlays and crowns in the posteriors, which were also in a cast technique, in the traditional technique. So this is very hard to transfer the wear facets by silicone index into the analog world. much easier, and this is a very good question, is to scan the splint again to correlate it and then transfer this into CADCam restorations. I have also a picture about that, but this is a development over the years that we followed.
So the answer is yes. This would be a potential way to do this as well. Clear,
absolutely.
clear. So
Scanning is a better way.
A very well listening and smart audience tonight. Thank you for that. Nice. Let me pitch you a few more questions. Mike Jordan writes, if a worn out posterior teeth, if the worn out posterior teeth are still in contact, do we have VD loss? I would say that's vertical deficiency loss, right? Or is VD maintained, is his question.
This depends on the patient. There are different of course, parameters that you have to analyze. It's a very good question because we also observe a lot of patients which have an over-eruption. That means teeth are coming out, and so you see very worn dentition, but actually you have not so much loss of the lower facial height. And there are some, from orthodontic standpoint, some options to measure this very clearly and to decide. The best will be a lateral radiograph to analyze, and then you can see is it a loss of vertical dimension of occlusion or not. Yeah, so it's very nice question. Some cases we have, especially open bite cases, you cannot, of course, open the bite again a little bit more or increase the vertical dimension. This is one example. In open bite cases, you can never proceed with a vertical dimension increase. Yeah, but there are other cases where you see clearly that's not a lot of over eruption there. This is I would say the major part of my patients that I see where we can add something in different ways, but we use orthodontic parameters to measure. And we are in an interdisciplinary university, so I can use orthodontic clinic to have a support in analysis all the time.
I was going to say, you unify several skills and expertises in yourself, but you also have a multidisciplinary team around you, so you apply all this knowledge as well. Let me make a quick shout out to Dr. Rawa Al-Rawi, who's joining us from Iraq. He writes, can we have a certificate of attendance? Well, for these type of questions, I would like to direct you to the EAO. You can find their website at eao.org. You can see everything about membership, but in short, I can already say, for these EAO Just Ask sessions, there's no certificate of attendance. It's just a lot of knowledge being shared on the web. So let me repeat my call to action. If you know anybody who might find this session interesting, make sure you share the link, because once we stop with this live broadcast, you can immediately watch the replay for as long as you like. Question from Stefan Vuketic. I hope I pronounced that correctly. What is your preferred method of deprogramming your patients prior to the bite registration for the splints? Do your patients wear any kind of deprogramming device for a few days, or how do you deal with this deprogramming issue? And for someone like me, can you also briefly explain to us what the deprogram, where that is for?
Okay, the deprogramming is, we can use equalizers. There's you know it probably. This is a special splint with liquid inside, and then you bring the positioning, and the goal actually is a starting point of a function for me is the centric relation, and this is my goal. In some of the patients, I find it directly. In some of them, they are so, how do you say, over tensed that they cannot work with you. So in these cases, in the second cases, which have very tensed patient, I would use an equalizer. You get it in the market, and then you can use it to position it to relax the patient a little bit, and then you try to find the right position for the centric registration. The starting point of the function is the centric registration, and if I cannot accomplish this with normal methods, I use normally equalizer to deprogram the patient.
Exactly. And for how long do you apply that then?
That depends on the patient. Sometimes some days, and he comes again, and I try. Sometimes for 1 week. Sometimes it's from our appointments. But I would say several days it's necessary at least.
Exactly. Wow. Thank you, Stefan, for that great question.
Very good
next question comes from Renate de Klerk. It reads, do you use the splint, between brackets, by rebasing the partial splint to transform it into a temporary bridge after preparing the teeth?
You can do it. You have two choices. But if you are doing it, you need an air abrasion system. So because it's like an eggshell temporary in this moment, and you have to reline it with a polyacrylate. Yeah, that can be, let's say, ProTemp, Luxatemp, Telius, CNS, all the manufacturers are providing a polyacrylate temporary material. So you can reline it. But what you need is A, airborne particle abrasion. Secondly, P, primer. And then C, the composite or the polyacrylate. It's possible to reline. It's a very smart idea.
Again, our audience is building on the knowledge. I like it. I sense from the questions that you are really part of the conversation. So that is a lot of fun. Mitchell Pierce from New Orleans, we heard about him before, sends in the question. He says, what is the maximum number of pontics between the abutments on the splint?
Excellent question. And I have to answer. You can use it for different applications. We use the splint in the meanwhile for patients with aplasia. That means they are edentulous in some areas in the growth area of 10, 14, 15 years where you cannot place implants in any case. So you can use it like a partial denture. Yeah, it depends on the height. If it's high enough, if the cross section is stable enough, you can use it for 2, 3 pontics in some cases. Yeah, no problem. But if it's very thin, it will fracture. And so if you increase the vertical dimension of occlusion, you have enough space for the splint. You can use it to, I would say, at least for 2 pontics, no problem. Perhaps for 3, if the vertical dimension is high enough, the cross section is strong enough, then it works.
And how do you determine this? Does your simulation software or your modeling software actually calculate forces in this as well, or is this by rule of thumb, or how do you determine what is enough vertical dimension to go wider?
I have either you're talking about the strengths of the material, or then you have no calculation just now. You have it with a zirconia ceramic, so a certain cross section of the software tells you how strong the bridges are, but not with these parameters of this polycarbonate. It's not existing yet. It's more experience that we have. If you talk about the vertical dimension in total of the patient that we calculate, this is something we have to approach by these orthodontic parameters. Lateral view, you can do 2D photogrammetry to measure the height of the lower face. You can use lateral radiographs to analyze and diagnose. And of course, we do a try-in, and the patient has to speak. Mostly we use a word, it's a German word, sorry, Aschenbahn. And then we ask the patient, do the posteriors touch each other? Are they in contact during you speak? And this is a freeway space in English that we need. And okay, even you make a mistake with a removable splint like this, okay, you make a mistake, it's a try and error, and you can modify. Yeah, it's no risk because you have the reset option. So sometimes we start a little bit too high, we adjust, and the patient adjusts, and then we simply transfer the final very satisfying result of our test drive. That makes the whole thing so secure and predictable.
Clear. In the meantime, Fernando Manfra is asking us to slightly go back to that topic of the deprogramming we just touched on based on Stefan Wuketis's question. He says, sorry, I didn't understand clearly. Do you use your hands to take the patient to central relation? And he comments, it looks a bit like an old-fashioned way to do that. What is
Yeah.
your
Perhaps it's not, I showed it like this. It's not that I push anything. Yeah. So I simply accompany the patient during the movement. It shows me a little bit, is he relaxed or is he not relaxed? Yeah. It's not perhaps like, from the 20 years, 25 years ago that we like to go into the very retro position. That's a mistake. We know it from nowadays. But I accompany the patient only to have a feeling, is he relaxed or not? Yeah. And then I can feel it a little bit. If it's very relaxed, I do not push anything, no power, no forces, but I accompany him into this jig position. For the jig, anterior jig, we use a pre-warmed high-filled composite, and then I light core it and I let him biting through. And if it's repeatable, then I can use it as a tripoidal position, like a tripod. Yeah. And then I can transfer it into the lab as a first starting. The advantage of the splint is actually, if I was wrong, maybe 0.1 millimeter wrong, the patient will correct it. And then you can
by wearing the splint and the wear effects that you will see. Yeah.
So we call it fine adjustment.
Clear. Fernando, I hope that answers your question and it's clear now. And thanks for taking the opportunity that we are live and making sure that you're entirely clear before you leave this live YouTube session. In the meantime, Renate Klerk sends in the next question as well. Do you sometimes use the polycarbonate teeth as a test of concept on titanium substructures on implants as well? And it's added before transforming it into zirconium.
In this case, if you place it, for instance, on titanium basis, I would recommend to use PMMA. It's easier. Yeah. The problem of the splint, this material is more for a removable denture. So it's a 23-hour splint. You can take it out and in. And if it's a permanent situation for several days, months, perhaps half a year, I would really recommend to use PMMA because we have not enough experience with the behavior directly in contact with the tissues with this polycarbonate material. It's more for the hard tissues. Yeah, but on snap-on on the teeth, but not for the soft tissues. In the moment, I would recommend more PMMA. There's a lot of blanks made of PMMA on the market. Almost every manufacturer will offer one, and this is a perfect way to go. You can bond it onto the titanium base and modify if you want.
Mm-hmm. And besides the fact that these solutions are available in the market, is there another reason for you to believe that there could be a risk with this material and the soft tissues? Or is it out of simplicity, or does your scientific background also tell you, well, there might be something there? Why you
No, we have actually not observed anything in any interactions just now, but we are always going scientific ways. And what we do in the moment, but it's not finished yet, we like to publish this year, is to measure the elution. So if you put it into artificial saliva or chromatographic devices, what comes out if someone gives, if you have saliva attacking this material, what comes out? Is there anything which we have to worry about? And so on our first investigations show there's nothing to fear about. Yes. But we will.
So your warning is the material is so new. This is all research that needs to be done before we can be safe and clear. Exactly.
And for PMMA, we know it already. Yeah.
Exactly.
So this is
that's the reason. That's your motivation why you say it like this.
Exactly.
Well, it's a nice segue also into because we're nearing the first hour. We're in our last minute. So make sure if you have an important burning question, ask it now in the chat. Otherwise, we're going to slowly move to an end. And that is always to look a bit forward into the future. Because this is where we are now, and it's still very novel and still very new, but at the same time, it's also being applied. You apply it to a lot of the cases that you come across. What would be your next steps besides us understanding the material better, like you just alluded to? What are some of the developments that you're looking forward to?
As I mentioned, in the moment, we need still the staining technique to make a nice color, but it's a new introduction now that we have monolithic, so one piece blanks, but bichromatic, so two colors, enamel and dentine, which makes it naturally already monolithic but bichromatic, nicer looking. So in the next steps, we are using it already in cooperation with the orthodontic department for young patients where we have aplasia of teeth. Let's say there are only remaining 6 permanent teeth for one jaw. So we use it for an interaction in the growth phase before we can place implants. And this is very nice because you can color these materials also into pink. So it looks like a denture, but on the other hand, you have no clamps to anchor this denture. It's still the snap-on design. And you can also, perhaps in the future, use it like a little bit in orthodontics, like a line, to remove some teeth. That's our next idea. So you have a colored material, which underneath you can adjust the positions of the teeth, especially in patients with ectodermal problems, syndromes, and aplasia of teeth. That's very nice. We use it as well. We did already in orthognathic surgery. So for LIFO1 surgery, and optic-gizzard pont for the mandible, to have a new bite. And we have a preview in certain softwares that the new bite is already milled into the new splint. And so we can guide the patients through the whole system, through the whole process. This is a future, actually. It would be, for the moment, I would guess, not a permanent material. So if you ask me now, is it a permanent material for crowns? I think might be an intermediate material for, let's say, 2-5 years, medium, long term, but not really long term. That's my...
Because I was going to say, when you apply this to growing patients, you might be looking at terms of 5 or 8 years, right? And
yes,
but it would be fit for purpose for those kind of timeframes. You expect?
Yeah, it will fit, let's say, I would guess for 1-2 years, but you have the data set. That's the advantage. So you designed already the outer surface. You can work underneath, and if it's fractures or if it's in a bad condition, you simply mill a new one.
Or the jaw is growing, you still know what your occlusional design is, but you just change the inner side of the
the substructure, I would say, the natural biological substructure.
Exactly. Exciting. And the other key thing is improving the aesthetics. So making sure that the splint is even more an immediate aesthetic solution.
Exactly. And hopefully we'll have very soon the data about the elution, if it's a safe material. I guess so, but we have to wait for the final scientific results.
These are some of the key things to come up and that we should keep following you for. This already kind of feels like a natural ending, but I also did promise just to my audience, if you have any burning questions, please submit them. And I noticed Stefan Woekert submitted a question where I feel, we already kind of slightly touched on that topic, but let's make sure, since we're live anyway, that we really explain it well. He's writing, so how do you exactly transfer the tooth positions and dimension, including the wear facets, from the splints to the final restoration?
So the best will be, the answer we're given, the most precise will be the scanning process. If you scan it and then you can transfer the data, you can load in the data into the software, and then you can give it out for the outer surface of the final restoration. It's a good question, if you work monolithic. So if you use a multi-layer material with a defined outer surface, it's fine. If the dental technician starts to manual veneering the framework, it's difficult. Then it becomes difficult. But by scanning and using monolithic restoration, especially in the posteriors, no problem. Perfect transfer.
Very clear. And now Fernando is also taking the opportunity and said, oh, don't go yet. I have a final question as well. You mentioned about, or we talked a bit about the potential longevity of these solutions. And he's saying, what is the most important aspect to decide about the time of using the splint? So I guess originally when you developed the concept, it was about we needed time before we go into final restoration. So then you're always removing it before it's worn out. But now, for example, in these younger patients, how do we know when the splint is done or decide that the splint is done?
If it shows discoloration, fractures, that's one very important specification of this material. They show sometimes very small cracks. Yeah, and you say, oh my gosh, the splint is gone, but it's not. So it's a specific characteristic of this material. They show small cracks. You can keep them. They are very small. They are not discolorating. But if it starts to
where do they often occur? Is it in the smile zone or in the back, or
mostly in the back, where you have very high bite forces. Yeah, you have 2.5 times higher, at least 2 times higher bite forces in the posteriors, and you see it more in the posteriors. That's true, Gerrit. And this might be a fracture, discoloration. Perhaps also the patient might say, okay, they don't taste anymore very well. Do a new one, no problem. The price is much lower because the CAD, the computer-aided design, was done already. So it's simply to milling it again in the machine. And so you drop the price, I would say, from the half. Yeah, 50%.
Exactly. So we're kind of back full circle. Somewhere in the middle, we talked about potential drawbacks, and that could be the extra cost of this protocol. Yeah. Obviously, that is an investment in then a perfect restoration afterwards. And you say, well, if you have to do another splint, obviously the costs are not as high as first time around because you already have the diagnostics, the scanning, the modeling, everything is there.
Exactly.
Clear. Very clear and very exciting session. I'm looking at the chat. There's the first thank yous coming in already. Beruz Arafnia writes, excellent lecture, like always. Thank you, Professor. And with that, I think we did indeed have a very comprehensive session. Thank you and compliments to all the audience members who so actively submitted your questions to make sure we made the most of this session. And thank you, Daniel Edelhoff, for joining us tonight on EAO Just Ask. Let me remind for the final time all our viewers that if you like this video, please hit a thumbs up on YouTube and share it with anyone who might benefit from this innovative pre-treatment option in prosthodontics that we talked about tonight, the Munich splint concept. And if you want to make sure that you know the latest and the most important concepts in implantology, make sure you hit the subscribe button at our YouTube channel right now, because you'll be the first to know when we schedule a new EAO Just Ask or when we publish any of the other educational videos that you find on EAO channel here on YouTube. It's all for free. Unfortunately, no certificates of attendance, but yet all the education is there. So make sure that you mark in your calendar. We go back to the first Monday of the month, which is May 3rd, which is then in 3 weeks already, where I'll be talking to Paolo Cavallo, same time, same place here on EAO channel. And with that, I'd like to thank you one more time. Daniel Edelhoff, thank you very much for your time tonight.
Great pleasure. Thank you for your attention. Very nice. Yes. Thank you.
And we'll keep following your work closely with all the outcomes that are there to be expected. Thank you all. Right. Looking forward to see you next time.
Thank you, Gerrit.